Bismillahir Rahmanir Rahim. What a pleasure to be in Bhurban and a bigger pleasure to play golf in the morning at 6 a.m. courtesy of Imran Fazal. And also a big surprise in cardiology meetings to have very eminent speakers like A.H. Amir. It's a pleasure to listen to him, and Maudat Rana. So I think cardiology is progressing to attract very good speakers as well. My job is a little simpler. We have heard all about prevention, and we'll talk about a little bit about it. But I'm going to talk about how to get all these things. We know it causes 17.7 million deaths. We know NCDs is an epidemic. We know it causes 60% of all diseases, and 85% of the global burden of CVD is borne by us, by the lower income groups. And we have to do something about it. And something latest about it, that the coronary artery disease seems to be more common in women as against men. And this is the data that we got from Tazeen Jaffer, that this is an excellent source of information. And also this data coming from Peshawar, prevalence of strokes shows us that all these risk factors are highly prevalent, and they're all above. So what is the way out? The only way out is preventive cardiology. We cannot offer angioplasties and bypasses, which is not an answer. Which is not an answer to CAD. We have to go out, and this is what I wrote in 2012, about 13 years ago, and we persist with that preventive cardiology is the only way out. The question we have to discuss it, why, where, and how to go about it. How to go about primary. And this is something interesting that I wanted to share with you. This is a study done, presented at 2013, about 10 years ago. And at that time, it was said, according to 2010 data, that there will be 3.87 million deaths in this age group in Pakistan. In years to be 2023, we are not too far away from 2025. But interesting thing is that if we do something about it, and I'll discuss that something, we can bring about 20% reduction, 1 in 5 reduction. So at that time it was thought that important things like tobacco, high blood pressure, low fruit intake, suboptimal blood glucose, overweight, physical activity, somehow or the other it put cholesterol at the end. All these things from 2010 are supposed to progress to 2025, especially if you look at tobacco use, look at high blood pressure, low fruit, and even cholesterol, it has gone up. So if we had adopted at that time a few measures which could have reduced tobacco by only 30% and reduced blood pressure by only 3 millimeters of mercury, fruit intake increased by 50, blood sugar by 5, overweight by 0.15 kilogram, physical activity increased by 50%, and cholesterol reduced by 0.1. If we had done that, we could have reduced 20% mortality. That shows the importance of preventive cardiology. How about secondary prevention? In secondary prevention, we did this study. Get stuck again. Computer technology at its best. Slides getting stuck.
उसका लैग आ रहा है, स्क्रीन का लैग है सर, स्क्रीन का लैग है, उसका लैग है, स्क्रीन का लैग है। कर रहे हैं ये बंद करके दोबारा लगा लें, लेकिन वो लैग उधर से आ रहा है, इधर से हो रही है स्लाइड।
इस जुर्म को भी शामिल कर ले मेरे मासूम गुनाहों में। Maudat Rana Sahib has sort of started this spree of शेर और शायरी जी।
उधर से जो आपके उधर की फीड है वो कर रहे हैं।
Seems to be a serious illness over here.
हो गया।
रेजिडेंशियल फ्लैट
कर दिया ना? नहीं वहाँ नहीं आया सर, मुझे लगता है ये उधर से आ रहा है, ये उधर से आ रही है, उतार में नहीं वो उसका टिश्यू नहीं है,
इसका मल्टीमीटर
उधर से मुझे लगता है आ रहा है, इसको या उतार दो।
सर मैंने तो कोई ऐसी बात नहीं कहनी थी।
वो कर रहे हैं उधर। नहीं इसका इशू नहीं है।
ना ऊंचा लगाया आपने, थोड़ा सा नीचे ऊपर हमें इसकी जरूरत ना पड़े। Was a small study that we did as to how successful is secondary prevention for coronary artery disease. And in a set of 843 patients, we found that people who were taking their drugs, following our advice, we were very well able to control their blood pressure, cholesterol, LDL, HbA1c, but still we could not make a bigger dent on their BMI, on their smoking, and on their exercise. Adding to that, how many people know about their ischemic heart disease and about this thing? This was a study from Tazeen Jaffer, and this just supports that median knowledge was only 3 out of 15. Only 14% patients knew about coronary artery disease, and about the risk factors, they only knew about 2 risk factors. So most people do not know about the risk factors and coronary artery disease. So in this sort of a setting, we have to empower the society. We have to educate the society so that now the road to prevention is through empowering the society. And this is what we looked at, putting knowledge and attitudes. So even if you have knowledge and if you have attitude, we've got great problem in putting this into practice. So what do we need? We have talked about prevention, we talked about all the risk factors, but there has to be some physical entity which has to propagate the agenda of preventive cardiology. So preventive cardiology is something which requires comprehensive, multidisciplinary, multifaceted interventions aimed at promotion of cardiovascular health. Promotion of cardiovascular health. So for this, we have to develop cardiology preventive sections. Now there is no, dissent on that preventive cardiology section should be there. But the things to add to it, that they should be properly structured, they should be adequately equipped, and appropriately financed. So these 3 things in which the administrators of cardiology departments, they would like to put money in the cath labs, but they would not like to put money into preventive. So it should be properly structured, adequately equipped, and appropriately financed so that they can do everything available, comprehensive, multidisciplinary for primordial, primary, secondary, and even tertiary prevention. What does this department or section has to do? This has to establish a close liaison between the medical units, between the diabetic units, cardiac surgical units, so that they can work in harmony. We have to have facilities for them to assess the risk factors, and in primary prevention, they should have primary special literature in the local language and detailed information on other risk factors for people who would like to learn about it, and they have to have regular discussions, video lectures for all the patients who are admitted into the hospitals, so that when they leave the hospitals, they have more knowledge about what has happened to them. Ideally, they should have free drug banks. That we have seen that unless we have free drug banks, and we can have very economical drugs to treat blood pressure, diabetes, and cholesterol. So for this, and then again, we should have some expert help where cardiologist knowledge ends about how to quit smoking, how to treat very high familial hypercholesterolemia, or how to treat obesity. He does not have the patience, or he does not have the enough knowledge. We need expert help from these preventive sections. They should hold regular seminars for general practitioners, for public awareness, and ideally, we should have a software and which we can put in this data, and of course employ social media for follow-ups and for reminders and for dissemination. What sort of a human resource we should have for this department? I mean, setting up is okay, but what does it mean? We should have somebody who has got experience of public health. Ideally, a person who has got MPH, or inshallah in the future, who has FCPS, preventive cardiology. Interventional cardiology should not have a preventive cardiology section. Secondly, supported by all the staff of cardiology, as is happening in Lady Reading Hospital, they should have a biostatistician, have a physiotherapist, psychologist, a nutritionist, and preferably a pharmacist. And my humble request would be, the more the number of cath labs, the more number of patients that you're serving as intervention, the more you should have the resources dedicated to prevention. And this reminds me of Naeem Tahir Khalil's sort of thing that he made, that they had a very huge interventional setup in US, Oklahoma, and they found out that their readmission rates were going up. They were having problems with their secretary. So in their insurance, they were told that unless you bring your readmission rate down to about 15%, you're not going to get money. So for that sake, they started this preventive department, and it became so successful that now they think that if you put money into prevention, this is the way to look after it. So we should have proper space for them. As much space as that we give to the cath labs. They should have exercise, a place for exercise physiotherapy, for patient education and counseling, offices for one-to-one counseling, and some waiting areas, proper rehabilitation equipment like treadmills, like ergometers or pelotons, and other things, so that at least it's a fully equipped sort of a center with computers, multimedias, access to event managers, media managers, and it should be sustainable. The important bottom line is that it should be sustainable. Maybe somewhere on the line, we should have Sehat Sahulat card that we have in Peshawar, and we have been enjoying the fruits of it, and we have been offering great services in the intervention. But I think, as was mentioned in this article, Sehat Sahulat card, a social health justice policy leaving no one behind. This was written by Khurram Nasser, published in JAC. And they were saying over there that we are putting in our money as catastrophes of what has happened before. If you put in our money, it will be far more cost effective for prevention. So what does this department will do, or section will do? It will work on primary prevention, it will work on rehabilitation, it will work on secondary prevention, it will work on primordial prevention. And it has to develop a public policy, especially big institutes like we have AFIC, RIC, PIC, Peshawar PIC. All these should have a policy, and then also have strong advocacy that if somebody comes and talks against anything, we can have a strong people to advocate. So what if you think about it? So do you have these preventive departments in different hospitals? They should be coordinating, and they should be coordinating at the level of provincial health services, along with the PCS cardiac chapters. And then this should all be going up, hopefully, and then looking at either Pakistan Cardiac Society Preventive Council, which should be made more effective council, or our own federal government, NHCR, and there we should look at things. As I told you before, that if you had done this thing, it would have cost 20% reduction. Who should be advocating that? It should be coming from there, going on to all these departments, so that there is a policy, and then we should look at the implementation of policy and also monitor whether this policy is being monitored at all, is being implemented at all. So my conclusion, my message is very simple, that we know about prevention, we love to talk about prevention, but we should put money and where the mouth is. And that, to conclude, that our burden of CAD is huge and it is increasing. And most NCDs and CADs are preventable. That's the best thing. So preventive cardiology has to be institutionalized. So far, it is not properly institutionalized, and it needs support from all cardiology faculty and administration. Preventive cardiology section should be properly structured. That's the first thing. Should be properly staffed and supported and funded. And of course, from this would come preventive research. We should have looking at our risk factors, at interventions, and we should have a research agenda. And with the help of universities, we can look at these agendas and try to develop, if we can look more into it. And there has to be a liaison between the sections to develop policy, monitor, implementation, and provide further insight. And I think Pakistan Cardiac Society should be taking the lead and playing the role over here. Thank you very much.